Good afternoon and welcome to the Home Health Value-Based Purchasing webinar series, which is co-sponsored by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America, or VNAA. This first webinar of the series is entitled the HHVBP Model 101. My name is Teresa Lee, and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. We're co-sponsoring, and so my colleagues Liza Greenberg, Interim VP for Quality at VNAA, and Heather Corbin from VNAA are also on the line, and we'd all like to welcome you. By way of background about our organization, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients in the entire U.S. healthcare system in support of quality and innovation. VNAA is a national association that supports, promotes, and advances mission-driven nonprofit providers of home and community-based health care, hospice, and health promotion services to ensure quality care for their communities. This webinar series is intended to provide the critical basics about the home health value-based purchasing model and to provide information in core educational subjects that are key to pursuing performance improvement in the context of the home health value-based purchasing model. As I mentioned, this webinar is a product of collaboration between the Alliance and VNAA, recognizing that there are many agencies, particularly in the 9 home health VBP states, that could benefit from this webinar series. We've made this webinar series open to the entire home health community. With that as background, I want to introduce our speaker today, and we're fortunate to have as our guest Chris Ataya of Strategic Health Programs, or SHP. Chris joined SHP in 2014 after spending 28 years in executive and consulting positions within the home health and hospice industry. In his role, he's responsible for product development and client relationships to help organizations achieve increased operational and financial performance through the use of SHP's industry-leading analytics platform and benchmark data. Prior to SHP, Chris was the CFO of the VNA of Boston and had worked at Partners Healthcare at Home as CFO and CEO. He has a BA in Public Health from Tufts University and an MBA from the Graduate School of Management at Boston University. Just a few housekeeping notes before we get started. First, Chris will speak for about 40 minutes and will leave approximately 15 minutes towards the end to answer questions. Please note that this is a webinar and we control the slides on our end, so please don't be surprised if you're not able to flip ahead. Second, your lines will be on mute. You can submit questions to be answered during the Q&A period through the webinar chat box on your computers or other devices. Finally, we will be making the slides available to participants after this webinar. We are also recording the webinar and will make the playback available as well. And with that, I'm happy to introduce Chris Ataya.
Thank you so much, Teresa, and welcome to today's webinar on value-based purchasing, our Model 101. The intention of this program is to give you a pretty good sense as to what's in the components of the value-based purchasing program and to share some insights as to what agencies should be trying to do to prepare for value-based purchasing. So I've identified 4 objectives for today: to list out those components based on the final rule and some updates from CMS's most recent Q&As, to talk a little bit about the implementation schedule as well as lessons learned from hospitals who also have been involved with value-based purchasing for the last 3 years. We're going to then look at how to calculate the total performance score. This is a score you will have that will kind of judge and be the basis of determining whether you will be in a penalty or a bonus situation. And then finally, what actions your agency should be implementing to be successful under value-based purchasing. So what is this all about? CMS, clearly has looked at value-based purchasing as a way to change paying for volume to paying for value. And they've identified a target to get to in 2018 where over 50% of all payments will be made through alternative payment models. So that's the incentive. That's what CMS has said they want to do, and is why home care has started with value-based purchasing effective this year. So let's get into some of the details and understand what the program is going to be. So in this section, I'm going to talk a little bit about what the goals were specific to home health, talk to you about the measures, what are they, and then something called new measures, something they've created to kind of get additional data elements that they want to track and consider measuring. We'll talk a little bit about the piloted states, how points are scored, get into a little bit of the larger small volume cohorts, two separate groups that they'll be using as a part of this program, and then finally some of those updates from CMS. So for the goal, really what CMS was trying to say is they want to have greater transparency, to be able to give data out to the public who are using these services, and to apply some of the competitive forces to be able to get agencies to build their care more based on value than over volume. Specifically, they said, hey, we want to see a better quality care with greater efficiency. They want to study these new measures and additional ones that I'm sure they'll be adding as a part of the Impact Act to kind of look at how they apply to the home care setting, and then finally improve and enhance how they report this information to the public. So what are those measures? Well, there are 21 measures that are coming from OASIS, from HHCAPS, and from claims data. They've separated these 21 measures into 6 domains, and you can see those listed at the bottom. This is a way to kind of capture different elements based on the National Quality Forum that really kind of supports these improvements across these different domains. So there are 21 of these measures, plus there are 3 new measures. These measures will need to be reported by the agencies through a web portal starting with Q3 data. Those 3 measures are influenza vaccinations, herpes zoster or shingles vaccination, and advanced care plan. Each of those are process measures, but they're not going to be judging outcomes on here. They're just going to be supplying or asking you to enter that data, and by doing that, you'll be rewarded for it. So those 6 domains that they've identified will also be kind of put into classifications, and there will be 3 classifications. 1, clinical quality of care, 2, outcome and efficiency, and 3, person and caregiver-centered experience. There will be a 4th classification, and that's going to be for those 3 new measures that they've identified. So the states, that are going to be a part of this pilot, there's going to be the 9 that are listed. You can see them colored on this map. But what was interesting is they tried to define 9 different groups of states such that they could look at similar characteristics of geography, sample size of those agencies, and patient characteristics. Their goal was to be able to really have a good pilot where they could test it in different areas. And based on those 9 geographic defined groups, they then did a randomized selection. And that's how they picked the 9 states that were going to be involved in value-based purchasing. For the point scoring, this is where it gets kind of interesting. For each of the measures that they've identified, the 21 that are on the list that we saw earlier, they're actually going to calculate 2 separate scores for each measure. They're going to calculate an achievement score, and they're going to calculate an improvement score. And how they'll do that is they'll create, using a base year, they'll look at all agencies in a particular state and create and calculate 2 values. 1, the threshold value, also might be considered the achievement threshold, and that's the 50th percentile of all of the scores within that particular state. They will also calculate a benchmark, and the benchmark is the mean, the average, of the top decile, and that approximates the 95th percentile. So for the base year, where they're going to do this calculation for both the achievement threshold and the benchmark, that will stay the same for the entire pilot, for the 5 years across the pilot. They will be looking at the performance years to be the 5 years starting in this year. January 1st was the beginning. So 2016 would be the first performance year through 2020. One thing about getting points, you need to have at least 20 or more episodes that are answered in each of these measures in order to get a score for that particular measure. But don't worry, if you have a couple that you don't have enough on 1 or 2 measures, they'll still be able to calculate the total performance score, and I'll show you that in some slides a little bit later on. For those new measures, they're not going to be calculating outcomes, but you will get scored, you'll get points just based on self-reporting of that data only. So that should be an easy one as long as you're ready to be able to collect that data and start entering it appropriately after the end of the 3rd quarter. So I wanted to give you a kind of a graphic, and we'll do this through a couple of different slides, to show you a little bit about what this means in terms of achievement versus improvement scoring. First you have to know that based on a particular state, they're going to calculate your threshold, this achievement threshold. And if you think of it from a bell curve, that's the 50th percentile. So take a line right up from 50, and this is an example they used in the final rule for pneumococcal vaccination. That reference point for the threshold was 47.4%. The benchmark was 87.5%. So that's that 95th percentile ranking. So really, what you're going to be wanting to do is to be somewhere in between there for generating points for achievement. And again, I'll get into that in a little more detail. So for the achievement, if you are equal or better than the benchmark, that 95th percentile, you're going to get 10 points. If you're less than the achievement threshold, you'll get 0 points. So if you're less than the median in your state, as they go to calculate this, you will get 0 points. Anywhere in between, you'll get essentially 1 to 9 points, or frankly, I think you can get a half a point, up to 10 points within that, within those 2 benchmarks. In this example, you are being compared, your agency is being compared to all other agencies in your state. And so they will do that as a part of calculating the points for each of the measures for the 21 that we talked about. For the improvement point, again, if you are equal or better than the benchmark, you'll get 10 points. But in this example, you're going to be compared with yourself. So they will go back to 2015 and look at what your scores were in that period. If you do better than where you were in 2015, you can then get points. If you do worse, you'll get 0. And in between, again, your base year 2015 score and the benchmark, you'll have the opportunity to get between 0 and essentially 10 points. So you're comparing yourself in the performance year, 2016, to 2015. I think this next graphic actually probably helps the most to kind of see how that works. Again, we're still using the pneumococcal example, and this is the same data out of the final rule. And what they showed here is that in 2015, all the way on the left-hand side of the graphic here, the agency had a score of 21.1%. So not that good. So let's go to the top of the page. You'll see with my little house there that the agency scored in 2016, I'll use that as the example, a 70.3. That's a pretty good score. The median for that particular period in reference point was 47.4. The benchmark was 87.5. And the way it works is they'll do a calculation to then say in between the two, you'll get points. And you can see it's kind of distributed equally between those 2 reference points. So based on the calculation, this agency for an achievement would get 5.64 points if they had a score, an outcome score of 70.3. For the improvement, again, it's going to be based on how you did in that base year. So between 21.1 and this new benchmark that they've calculated, again, you'll see a distribution of scores between the two. And when you look at where 70.3 would be in that scale, you actually would get 6.906 points. Now, this is one measure, and what we've said is you'll get the higher of either achievement or improvement, and as you can see in this case, the higher number is the improvement range. So you'll get the 6.9 points. So that's essentially the way this will work for each of the 21 measures that are going to be attributed to these outcomes for value-based purchasing. Now, we do talk about different sized agencies, and what CMS said is their goal was to be able to group like agencies for kind of performance reporting, and they decided to break it down into two subgroups, or cohorts, a large cohort and a small cohort. And they decided to determine which one you're in based on your home health caps participation. If you are exempt from HH caps because you have fewer than 60 eligible patients, you will be in the small cohort. If you are not exempt, you are a participant, you'll be in the large volume cohort. And they gave a graphic as to what it looked like as a part of reporting in the final rule, what percent were small versus large across the different states. What's interesting is in Maryland, Tennessee, and Washington, there was just literally just one or two. And so they will not be able to break that into a separate cohort in this example, so they will actually all be part of the same grouping in those particular states. Now, for performance reporting, CMS will be reporting to each of the agencies quarterly. And each quarter, they're going to show you how your scores were, based on what you've scored at that point. So the first report that will be available will be this summer in July, where they'll look at the 2016 Q1 data. What they've said is agencies will have an opportunity to contest their scores within 30 days of receiving that report. The importance there is they just want to make sure they're getting all of the OASISes in, and so that they give you at least a chance to make sure that it was accurate. When the year is over, and they're now starting to calculate the total performance score, the TPS, and kind of identify whether you're in a bonus or penalty situation, they're going to notify agencies as of August 1st after that close of the first year. So 2016 has been completed. They're going to do their calculations and report on August 1st to each of these agencies. Again, you'll have 30 days to be able to request a recalculation. Then they're going to report, they give you a final report by November 1st. And then the data that they're providing to you individually as agencies will also then be made publicly available at some point after that. So finally, CMS responded to a lot of questions that came up through some of their open door forums. I remembered one in November where there was a lot of good questions being asked, and some of them have been answered. Most of them have been answered, but I kind of picked out some of the ones that I thought were the most interesting or helpful. The first thing is this EIDM, standing for Enterprise ID Management System. This user ID is how you will be accessing the new portal. It's also where you're going to be submitting that new measure data, looking at your quarterly reports, your annual reports, and understanding your payment adjustments. If you're an agency in one of those 9 states, you need to make sure you get those user IDs very quickly. In addition, you also need to assign and identify a point of contact. So they describe that a point of contact will be needed for each CCN. But they also said that one person for larger enterprises can actually be the point of contact for multiple CCNs. Another answer that they responded to is, even if you're a very, very small agency, only 10 cases per year, all agencies in the states are required to participate. You may not be eligible for scoring in that first year, but as you grow, you may, and again, all will need to participate. One of the most interesting and important news that we learned from the Q&A is that the OASIS measures that they'll use to calculate your scores are going to be on all assessments related to Medicare fee-for-service, Medicare Advantage, Medicaid fee-for-service, and Medicaid managed care. That was a question that still wasn't clear until they produced these final Q&As, I think, on the 29th of December. Very helpful to know that, because that's going to be important as you're kind of improving your scores. The secure portal that you'll be using to be entering in data will become available, so you can start looking at that in March. But actually, this next bullet was interesting. There were a couple of measures, 4 or 5 measures actually, that are not currently on Home Health Compare, that they didn't define the numerator and denominators as well as I think the industry was hoping for. They had answered that they were presenting that in a webinar that I thought was scheduled for, they implied, tentatively scheduled for January, but I have not yet seen that. So there are still some measures here that I think, we're not sure exactly how they're calculating. And for those of you in the 9 states, you're responsible for improving those scores, so hopefully we'll hear about that soon. The benchmarks and achievement thresholds for the OASIS measures will be made available to the agencies in those 9 states in April. The benchmarks and achievement thresholds for the HHCAHPS and claims measures won't be available until July. So in some respects, you're not really going to know where you are relative to your achievement points, because you might not know exactly, well, what's the base year? We won't know some of those until April and then in July. To help on that, CMS did say that they are pulling together data for benchmark and achievement thresholds for fiscal year 2013 and 14. The intention there is, if you can see how those were set up for those 2 years, since there's not dramatic changes year to year, you would at least have an opportunity to get a sense as to where you were relative to those 2 reporting periods. And hopefully that would be helpful. So let's talk a little bit about the implementation schedule and some lessons learned. The implementation schedule, as we said, there's going to be a baseline year of data that they're going to collect for 2015. And in blue, you can see that across the years, they'll just be moving forward each year the performance years from 2016 to 2020. The payment adjustment relating to that first year, though, 2016, won't occur until 2018. And as I'm showing you both the proposed rule and the final rule, you can see in this example that they actually reduced the penalty bonus in the first year, and then in 2021, they did make an adjustment to kind of, take away a little bit of the pain, if you think of it that way, from 8% to 7%. So with hospital value-based purchasing, again, they've been doing this for 3 years. What do we know about them? Well, what we know is the number of measures and the domains that they use have actually changed over these last 3 years. So that's kind of interesting. If you think about what we have today, we've got the 6 domains, we've got 21 measures, but as Medicare and CMS had said, this is the starter set. So we have to conclude that it's likely we're going to see changes in these over time. With hospitals, they also give points for consistency if you're better than the 50th percentile in each of the patient experience dimensions. So that's interesting. That's not what they've offered yet for home health, but it may give you an insight as to what they may be thinking. The bonus and penalty, like with home care, is going to be netted against the withholds. So in that first year of calendar year 18, it's going to be adjusted so that you'll get the net amount, which kind of helps cash flow in that way. And then unlike the home health proposal, the base year for hospitals actually change every year. That's not what they're suggesting for home health, but it is interesting to know that that's how hospitals have changed. And this is just a quick example of how it's changed across the hospitals. And you can see they've added new domains, outcomes, and efficiency. They've changed the number of measures as you look at the bottom. So I think we should expect that's going to be the same thing for home health. So let's talk a little bit about the total performance scores and the financial implications to agencies. So CMS is proposing that the TPS and payment adjustments would be calculated on each agency's CCN. So therefore, it's only based on services provided in those selected states. The 21 OASIS, HHCAPS, and claims measures will represent 90% of the score. Again, you have to have 20 or more episodes to be scored on a particular measure, but across that will account for 90% of your total score. The 3 new measures will account for 10% of your score. If a home health agency does not meet this threshold to generate scores on at least 5 or more of the clinical quality, outcome and efficiency, person and caregiver-centered measures, then there will be no payment adjustment. So neither would you have the opportunity for a bonus or a penalty, so essentially you'll have no adjustment in that particular year. So I wanted to give you an example of what this could look like, and I've just brought forward the kind of view of the 21 measures. And in this example, I said that this was a small volume agency, so not exempt from HHCAPS, so there's no scores there. And then I just kind of picked some scores and I just threw some numbers in and said, well, let's say they got 10 points for ambulation, and you can see the numbers as they work their way down, essentially gaining about 88 points across those measures. Now keep in mind, this is an integer value. What Medicare is saying now is that they're going to go out to the 3rd decimal point when calculating scores, but I wanted to keep it simple, so I've rounded the numbers in this example. So they had 16 available measures. Again, 5 they weren't available because they were HHCAPS, and so they had 88 points. So what was the total possible points for those 16 measures? Well, 16 possible measures points is 10, so that would be a total of 160 possible points. Since they had 88, we would divide that by the 160, and so they would score a 55. But this is for the 90% of the outcome, so we'll multiply the 0.55 times 90 to give us 49.5 as a score. If all of the new measures were entered appropriately, and there's a possible of 30 points out of a maximum of 30, they would get 10 points for entering those all in. So in this case, they would get 59.5 points. So the reimbursement impact of those points are going to be dependent on really 2 key things. What was the range and distribution of the agency's total performance scores in your particular cohort within your state? If you had 59.5 as a score, it's going to really be a question of how is that relative to everyone else's scores. Are you in the middle? Are you at the top? Are you at the bottom? And that's going to determine part of what you will get for an adjustment of bonus or a penalty. It's also going to be dependent on the agency's base operating HHRG payment amount, because they're going to be looking at your base rate that if it's in the first year, they'll be taking 3% essentially and creating a pool and redistributing that. And so depending on what the size of the operating base payments are, that's also going to be dependent on what kind of adjustments will be shared. So the value-based payment, again, is going to be an adjustment based on base operating amount. The rule requires that these be distributed across all agencies in a zero-sum game. So it's whatever they adjust out of the payment for that, again, 3% across all agencies, they have to redistribute it back to all those agencies based on their total performance score. And the rule also requires that value-based incentive payments be based on your actual performance, so that's why they're calculating the TPS. So I've got an example of what they shared in the final rule, and this one was figure 9 with an 8% reduction. And what they're going to do to kind of redistribute those funds is they're going to calculate what they call a linear exchange function, this LEF. And this is a way for them to be able to take the funds based on your score and calculate essentially what you would get back to redistribute those funds in that zero-sum way. So if you look at the column, this C3, it's kind of in the middle of the page, the sum total of $276,178, and in column 6, you can see that they're redistributing. So in the end, it's really the dollars are coming out, the dollars are going back in, and that net amount is where they're calculating on the furthest to the right column the actual adjustment amount that would be applied in the adjustment year. So, for example, if you look at the TPS scores in the second column, let's see, the worst one, it looks like, is Home Health Aid 3, Agency 3. They had 22, and go all the way over to the right, they had the lowest or the worst payment adjustment because they had the worst score. The one that had the best score was HHA 4. They had 85 points total TPS, and as you can see, they had the highest bonus in that example. So again, it's this redistribution of the funds to apply for those that are top performers. I went back and I looked at the hospitals, and I saw something similar in terms of what I think we're going to see in home care, which is that approximately 75% of all the agencies are going to be in the middle. So in this particular year for the hospitals, 75% are between -0.5 and +0.5, and they shared something similar to that in the final rule, where they showed, about 60% of the agencies in that first year were going to be between a -1.2 to a +1.8, 1.9. So because there's clustering, there's a bell curve, we'll see more in the middle, and only out in the extremes will we see the higher penalties and bonuses for those particular agencies. They also shared some examples of what these points would look like by each of the states, and this is an example of the large cohort. They used 2013 and 2014 data, and they said if this is how they would have scored on at least the available measures that they had back then, here's the range of the penalties and bonuses that agencies would have. And you can see there's some differences. And those differences are, again, a function of where agencies in that state's performance were relative to each other, as well as the volume of dollars associated with those agencies in each of those states. So I wanted to give you an example of what this looks like more literally. We talk about linear exchange functions, so it's got to be linear, right? So I took 50 agencies. I used similar scores that were in the final rule, kind of small volume agencies, and I did my own little bell curve. But I wanted to show you, based on the calculations of those scores, and you can see the total performance scores on the bottom between 10 and 100. Look at the adjustments. If you scored a TPS of 10, you'd have a -2.4% adjustment. If you scored 100, you'd be 2.7. But look what happens. It's actually a straight line. So this is the linear part of the LEF. And that will happen no matter what the scores were in that particular cohort, that particular state. That's just the way the calculation would work, to have that same scale, that same linear function. But what's also interesting I kind of said, well, what would happen if many of them are in the middle? It's not as much of a bell curve, and there are a lot of poor performing agencies in that particular state. And in this example, I just kind of threw some numbers in. You can see in blue, what the agency count might be. But I was fascinated by the fact that even though the penalty and the bonus, or what they were taking out, was 3%, if you look at the agency that got 100 as a score, they actually potentially could get even more than the 3%. In this example, they could get 3.4%. So what actions? What should you be considering right now? What should you be implementing to be successful under this program? And the first thing we would advise and you should be looking at is, how are my scores? How am I doing today? What's my performance improvement program look like? So have I been seeing improvements over time? Have I, has my quality and satisfaction scores been going up? How do I compare myself to other agencies in the state? What about my star ratings, the quality of patient care? How does that compare to the state star ratings? And where are your best opportunities to improve? Is it process measures? Typically a little bit easier, especially if you're not performing as well. You can usually get that up more quickly. Outcomes, not as easy. And HHCAHPS, from my experience, that's probably one of the hardest ones to improve on. But where do you focus? And so one of the things I wanted to look at is, where and how has the industry been trending? So you might have been improving. How has the industry been improving? And in this example, I went and I looked at the Home Health Compare outcomes from October, the ones that were reported online in October. And as you can see here, a lot of the scores, and many of these are star rated, by the way, many of them have improved. And some have stayed flat, like the HHCAHPS have stayed relatively flat. What I think is important, if you look at this data and you look at how it's changed, so in this example, how many percentage points did oral meds change from 11 to 12? It went up by 2. From 12 to 13, it went up by 2. From 13 to 14, it went up by 2. So from a percentage perspective, that's 4.3%, 4.1%, 3.9%. So you can see that across these measures that are available, at least today, many of them have improved, some have stayed flat. But as you start to think, where do I need to be? What score do I want? How do I make sure that I am better than the median? I'm better than the state average. You have to take into account that everyone's improving. So as you try to set goals for 15 and, well, for 16, frankly, you'll need to be able to keep that in mind. So I just kind of shared with you from a trending perspective, one option that you would have is take all your scores, put them down, look at what's happened in your particular state, look at how these scores have changed, and maybe do a trend line, kind of trend it out and say, if oral meds, excuse me, had been 47 to 49 to 51, if you trend that and use like a logarithmic graphic, you'll see that it goes up to 53.4. And so you can use a linear trend line, a logarithmic trend line. So what's important is to really ask yourself, where do I need to be ahead of the market? Because you want to improve, but you want to do, if you can, better than the market. What about the measures that aren't on Home Health Compare? So there's 5 of them. So discharge to community, care management types and sources, prior functioning ADL, IDL, the data collection for flu vaccines, and then reason vaccines not received for pneumococcal. Hopefully we're going to see what those are soon. Again, they're not on Home Health Compare. We're still even not sure how they're going to calculate it. SHP has looked at discharge to community in the past, and we see, as we saw with some of the other outcome scores, that they have improved over the last 4 years. So you can see some of those improvements on the graphic down below. Another important element that you need to kind of think about is where are you relative to your particular state. And again, I used the Home Health Compare scores posted in October, and with the example of Massachusetts, I found it interesting that in Massachusetts, all of those value-based purchasing measures that are reportable are better than the national except for 2 cases, which essentially says that in the national scoring, especially on the star measures, you may look good. I may be getting 3 stars. I am at the national number. But as you go to look at the value-based purchasing measure scores, if in Massachusetts the ambulation is at 66 and I'm at 63, I may be below the median. I may not be getting any points. So it doesn't necessarily mean if you're good with the stars that you're necessarily good for value-based purchasing. I think that's the point I wanted to make here. For the new measures, there was a webinar that CMS conducted through, I think on January 28th. So now you have the form sets. You have the questions that you need to be able to answer to be able to report the data for those 3 new measures. So take a look at that if you haven't yet. You'll need to be collecting data effective July 1st through September, that 3rd quarter, and you'll have to submit data by October 7th. It's suggested that you centralize this collection and reporting, conduct your own dry run to make sure you have that data ready. There's no reason why you shouldn't be getting the points for entering that data into the portal. And be ready to start entering on the first day that the portal is available, just to make sure that there are no glitches. So when you think about your outcomes, what's important is, look at those measures that may also be star measures. You almost get like a twofer if you can improve both the value-based purchasing measure as well as the star. Strive to be at or above your state averages and review your CASPER reports. Look at demographic information, outcome scores, risk adjustment scores, and any other data analysis that you might have available to you. There's a lot of data out there already. On Home Health Compare website, you can see how you're doing for different measures against the states that you're in. You can also see how you are doing relative to the star ratings. That gives you some sense of how you are doing for at least those 9 measures relative to the state. This is an example of a benchmark report, and companies like SHP include OCS, Home Health Gold, TPS Plus. They have reports where you can kind of see how are you doing, your score against state and national data. And as we do here, we give you a sense of, by using color, are you green, are you red? And if you're red, that means you're not performing as well. This will help to isolate what measures you might want to be working on. Looking at trends, if you're graphing your data, that's helpful to kind of see how you're doing over time. Especially if you're implementing new programs, you want to make sure that you're getting the impact, the improvements for those measures. And if you have dashboards, another way to be able to identify where you may have lows in your outcomes, where you can kind of isolate and make the kinds of improvements that you need to do. So for a good quality improvement program, you need a good team. You should start with 2 to 3 outcomes for improvement. And look for where you think you have the greatest improvement. Is it a process measure? Is it an outcome measure? Assign responsibility, set your time frame, and aggregate the results and make it visible. Share it with others. Identify the good and the not so good performers. Drill down where you can by team and clinician, and hold everyone accountable for improvement. So a good quality program, as you can see, find someone who's responsible. Make sure you assign those that are going to be involved with the improvement in process and service, what data will be collected, the frequency of data, and you can see some additional items here that you should be working on. Set up a chart of time frames. When will you be reporting on it? Who are you going to report the data to? Who's responsible for those particular areas? Again, if you have a particular area that you're not working so well on, drill into it. Find out, is it because of one clinician? Is it because of one team? Is it because of one provider, perhaps within your enterprise, that's not as successful? Isolate it, get to where you need to make the change, and make the change. And please make sure you hold your staff accountable. If you have a staff that just can't get it, you don't want them to bring you down. You might have to make changes if that's the case. So a good QI program is great, but there's more that you need to be doing. We say best practice is ensuring that your OASIS are as accurate as possible, because that's a key to your success. Make sure the starter care assessment truly reflects the patient frailty and disability. Enhance your education as appropriate, continuous education at specific intervals, validate that they understand and that you're testing them. Make sure that they retain it and utilize the OASIS Q&As. If you have scrubbing available through any of your software, that usually tells you where there's issues or problems, inconsistencies. Use that, track that, and make sure that those are being used appropriately. So I'm going to end with this slide, and then we'll take some questions. But truly, this is a lot. This is very complicated. I'm continually amazed at how much is being forced on agencies to have to deal with continuously, and this is just another one that they're dealing with. So evaluate the impacts, even if you're not part of the 9 states. Use dashboards and reports to identify negative trends and quality measures. Do scorecards to hold staff accountable. There are these OASIS scrubbing tools. Use them to proactively prevent and resolve issues at the episodic level. Identify specific performance improvements, educate staff, set goals, monitor progress, and reward your staff when goals are met. And initiate a continuous cycle of improvement, I think will be very helpful and supportive of your agencies. So that is the last slide, and I think we'll have a chance for questions and answers. And so I'll turn that back over to Teresa if you're the one that's going to be presenting the questions. Thank you.
Absolutely. Thank you so much, Chris. That was, I have to say, when you first showed your presentation to me, I thought to myself, well, that is a very exhaustive review of home health value-based purchasing, and I'm sure that there are a lot of folks who are tuning in to this webinar who are thinking, wow, it's a little bit like drinking out of a fire hose. But I think it's such critical components that we need to make sure we all understand in relation to home health value-based purchasing. I want to take this moment to remind everybody that if you have any questions, if you could please enter them into the chat box on your webinar screens, and if you send them in, we'll make sure that we ask them to Chris and try to address as many as we can. So while others are thinking about their questions, I guess I'll ask you, Chris. I mean, you mentioned that in the hospital context, there have been iterative changes over time to things like the measures that are used and even maybe the domains. I'm wondering if you have any sense of what kind of iterative changes we might be able to expect in relation to home health value-based purchasing, given that it's so new, and that one interesting thing is that home health value-based purchasing is being run out of the Center for Medicare and Medicaid Innovation, and that it's called a model, not a program. So I'm wondering if you've got any thoughts on what providers might be able to anticipate in terms of change in the future.
Yeah, well, thank you for asking. I think that one of the reasons why they change measures is because, as with the hospitals made some pretty good improvements and got to a point where there was really no more room for improvement. They were kind of, they topped out, as they say. So that's when they would typically retire a measure and then maybe add in a new measure. I mentioned that there are new things being added over the next few years as related to the Impact Act. I can imagine that as they look at that, they'll see perhaps new measures that they're going to want to track and measure. So I think that will be one way for change to occur. And then finally, what's the priority? If you look at some of these outcomes, if you look at some of the classifications that they've identified, I would think it would be likely that they'll start to weight those differently. Right now, all 21 are weighted the same. So with the hospitals, they kind of looked at where the priority was, and one thing that we're not being measured on today is cost efficiency, but that's an important part of what the ACA was all about. So I would imagine they're going to find a way to kind of create a measure that they're going to want to use to look at essentially cost efficiency.
Absolutely. Thank you so much. So we've got a couple questions here. The first is, how do we determine if we are included in the pilot? We are a Rhode Island-based agency but service a small patient population in Massachusetts. Also, would we need to break out quality measures for both states?
Yeah, so I think what they've indicated is that it's going to be based on where your CCN is based out of. So if your agency is in Rhode Island and that's the basis of your CCN, you would not be required to participate in the value-based purchasing. If you had a separate CCN in Massachusetts, then perhaps I think you would be participating, but you should be checking with the CMMI group to make sure you get that right. So would you need to break them out? Again, the OASIS will follow the CCN. So if, again, it's all being reported out of Rhode Island, you would not have to separate them between the two states.
Okay, great. Here's one more question, and the question is, can you draw a line from home health value-based purchasing to the Impact Act? And I think what's maybe meant in the question is really, is there anything that requires is there anything in the Impact Act that specifically, references or states anything about home health value-based purchasing? And vice versa, was there anything in the home health value-based purchasing provisions of the final or proposed rules from last year that made reference to the Impact Act?
Yeah, that's a good question. I'm not sure what's the best way to answer it. In the final rule, they do talk about the Impact Act and the fact that it's adding new measures. I think the possibility, and I think I said this just a little bit earlier, is that they might use some of these new measures that are coming out as a part of the Impact Act to then perhaps in the future consider as an option as a new measure for value-based purchasing. So I think that's where the connection is. I'm not sure I see an additional overriding connection, but that first one I think is probably more likely.
Right. One of the measure domains that was in the Impact Act, I think, is discharge to community. So, and there are measure specifications, draft measure specifications, for which there was a comment period, a public comment period pretty recently, just on the CMS website. So, it wouldn't surprise me if the discharge to community measure that we don't really know the specifications of yet, if it turns out that it's that's what they'll use.
That's a great point, Teresa.
Yeah. But to your point, there's nothing in the Impact Act, there's nothing in legislation that mentions home health value-based purchasing. They do make reference to the home health quality reporting program, but that's different.
Yeah.
I am not seeing other questions right now. I want to remind everybody that this webinar on the Home Health Value-Based Purchasing Model 101 is the very first in a webinar series that the Alliance and VNAA are co-hosting. We have another webinar that's being planned coming up on February 17th at noon on Performance Improvement 101. And so you can see the link there on your screens so that you can click through and register for that one as well. The way we're thinking of it is that there are some core building blocks that everybody should try to make sure that they've got a strong handle of in order to do their top drawer best to try and succeed in the context of home health value-based purchasing. And certainly the core basics of performance improvement are a big part of that. So we've got 2 webinars. There will be a Performance Improvement 101 and then a 102. And then following that, you'll see additional webinar topics released and announced. So if you have any questions about any of these matters, please feel free to reach out to me, Teresa Lee at the Alliance, or my colleagues Liza Greenberg or Heather Corbin at VNAA. We'd be happy to make sure that you're on the appropriate distribution list so that you get information about these webinars as they are announced. So without seeing any further questions, I want to take this opportunity to just express my tremendous gratitude to you, Chris, for speaking so eloquently and in such detailed fashion about the home health value-based purchasing model. I'll remind everybody that we are going to make available to participants the slides as well as playback of the webinar. And with that, thank you to all of you for participating today, and I hope everybody has